Thank you, Arun, and thank you for inviting me here to India. It's my first time in India. So I'm going to talk to you about our experience with intraarterial chemotherapy, and I'd like to acknowledge my coworkers, Dr. Abramson, Goban, Ira Dunkel, Scott Brody, and Dr. Jasmine Francis. Intraarterial chemotherapy was originally tried and published in 1955 by Dr. Reese, who actually injected it directly into the carotid artery. That had some complications and it was disbanded, but later again tried in 1966 with the same complications. And not until 1993, when the Japanese used a balloon technique, they had success in intraarterial delivery chemotherapy. And since then, in 2006, we started using microcatheters in New York. And we're about to have our 10-year anniversary of intraarterial chemotherapy experience, and I'm going to try to condense 10 years of experience in 10 minutes. So the format for intraarterial is actually we place a small catheter within the femoral artery and take it up into the common carotid and then into the internal carotid. And you can see in this video, which in about a second, the catheter tip is going to go right up, and this is real time of a catheterization with Dr. Goban. And here it comes. You can see it going up into the internal carotid, and it's going to stop at the first branch, which is the ophthalmic artery. And as it clicks around over to the ostium of the ophthalmic artery, you'll see a little flash of dye that goes into there, and that's how we technically do the catheterization. We don't put the catheter directly into the ophthalmic artery. We stay at the ostium. And so we'll get a good flush, and the chemotherapy can be delivered into the eye. And you can see here there's actual blushing of the choroid and some of the surrounding uveal vessels. But most of the time we can get in through the ophthalmic artery. But in certain cases, because of the anatomy or because there is no ophthalmic artery, which exists in about 4% of people, they don't have an ophthalmic artery, we'll use a balloon catheter, or we'll go retrograde through the middle meningeal artery and backflow into the ophthalmic. And so if we see our success, and this is fairly recent data, about 75% of the time we can do the ophthalmic. We'll use the balloon 14% of the time, and then we'll use the backflow through the middle meningeal 8% of the time. And the reason why we do intraarterial chemotherapy is for intraocular tumors. It's not good for extraocular extension. There hasn't been studied of any effect of it with extraocular disease or optic nerve disease. We use it for large tumors that have seeding, and we only do it in children above 3 months and that are greater than 6 kilograms in weight. And this is mainly because of the size of the femoral artery and the complications that can arise from trying to catheterize a small femoral artery. If we do have younger children, we'll give them what we call bridge therapy, where we give them single agent intravenous chemotherapy until they get large enough that they can get intraarterial chemotherapy. The drugs we use are about 3. We use melphalan as a mainstay, carboplatin, and topotecan. And usually it takes about 3 to 4 infusions of intraarterial chemotherapy for a treatment. We've ranged during our 10 years from just 1 treatment to 10 to be successful. So our early results were fairly promising. In the Reese-Ellsworth classifications 1 through 3, 100% of the time we were able to save eyes. And in 4 and 5, we got up to at least 2/3 of advanced eyes. And you can see this large tumor here regress nicely, as well as this one. And it's very dramatic when it works in these advanced eyes, and we've had durable responses. And now, as we gather more data and more time goes by, our success rates are improving. And in a recent publication with our group D eyes, we've gotten even more success, up to the 85% category with group D in naive cases, where we're about, with the eyes that we retreat, about 70%. So in our classification, or in our success rates with group D and E eyes, these are advanced eyes. If you take these eyes and look at them specifically, these are Reese-Ellsworth group 5B, which means they have vitreous seeds, and group D or E eyes. And with that, we've obtained up to 67% of globe salvage for that. And that is actually not a recurrence, but usually it's a testicle eye that's removed for blind people. This is eye salvage and not recurrence. Our recurrence rate is actually fairly low. It's about 10%, and I'll get into that a little bit later. But this is eye salvage. So if you have a kind of a testicle eye that becomes painful, that's one of those late stage eyes that were removed. If you compare this to intravenous chemotherapy with the group D eyes, you can see that over a series of different studies, the salvage rate is about 50%, where with the intraarterial chemotherapy we have improved on the more advanced eyes into the 60, 70, 80% in some cases.
The increment is 15%, from 50 to 65.
Okay.
So 15% improvement. Just keep that in mind.
And so if you look at, well, okay, we're saving these eyes, but are these blind, painful eyes that we're saving? Are we really making an impact on vision? And, the answer is kind of. If we look at the ERG results, it's kind of our best representation of vision. About 20%, now this is long-term data, about 20% of patients' ERGs get worse over time. So Dan was talking about long-term effects. Well, we've been looking into that, and yeah, the ERGs do get worse in 20, but in 80% of the patients, the vision either gets a little bit better, or the ERG performance gets better, or stays the same. Now, staying the same from a blind eye to a blind eye is still staying the same. However, you have to consider that when you're thinking about, is this really the best thing to do? So you can see here's an example of a ERG that are improved. Here's a group D eye that was treated, and you can see slowly with resolution of the tumor that the ERG improved. And this happens. So we were talking about recurrence. So we looked at what happens to our recurrence. So we defined recurrence as recurrence after 3 months of ceasing treatment of intraarterial chemotherapy. And we had about 30 cases in this series when we looked at about 300 patients. And so that's about a 10% recurrence on intraarterial chemotherapy. And then we treated them again with the same type of intraarterial chemotherapy, with or without the addition of other modalities, including intravitreal injections. And we were able to salvage another 80% of those. So really, if you look at it, there's about 2 or 3% of patients that we tried and tried again that we couldn't save the eye in those cases. So I thought it was fairly impressive from that. So is it safe? Do our patients die more than others? Well, in a recently published article about some of the big centers that do intraarterial chemotherapy, if you look at the 534 patients that they treated, there was one, and these were done in big centers like our center, Philadelphia, in Switzerland with Francis Mirnier, and with Dr. Shintada in Argentina. And we had one death from metastatic disease, and that patient actually had a recurrence and refused to come back for treatment. So overall, we haven't seen a higher amount of deaths with that. Now, we do have metastatic disease, and there's about 4 cases that did develop when we treated them, but we were managed to save them with high-dose chemotherapy. And they are still alive and with a durable response. So here's another example of a fairly advanced eye and before and after treatment. Again, another big tumors. With fairly dramatic results. So all right, so that's the great things about intraarterial chemotherapies, and I'm going to try to be as transparent as possible, and we're going to reveal all the kind of technical complications that we had with the procedure. In June of last year, we compiled a list of all the different complications. I'm going to share that data with you, but this is on about nearly 400 eyes with about 1,200 infusions. So it's a fair amount of data. We had about an equal amount of males and females, and the ages range from 1 month to 21 years. And a lot of these patients had previous treatment, so we were doing salvage treatment for the majority of these eyes, more than 60%, because they would fail other treatments, come to us, and then try to be treated. So this is about 1,200 procedures that were done. Some of them were done bilaterally, about 200. As we talked about, the technique we use is about 77% with the ophthalmic, 14 balloon, MMA was 8, and then we did some deep temporal arteries and common carotid balloons in just 2 other cases. We used the same drugs that I spoke of before. The doses range from 2.5 to 8 milligrams, 30 to 80 milligrams for carbo, and about 0.3 to 2 milligrams with topo. So what are the extraocular complications? Well, cerebrally, we did have one patient that had 2 weeks of hemiparesis. MRI scan showed no effect on the MRI, and it did resolve spontaneously, but that was a true CNS complication that we had. About 25% of the patients during the procedure will have a bronchospasm reaction where their tidal volume drops dramatically, and this scares the anesthesiologist, and it initially scared us, but it's treatable. It usually happens on the second infusion, not the first, and it's usually in younger patients than older patients. And it's treated with epinephrine 1 microgram per kilogram, and it resolves spontaneously, and it's usually controllable, and we haven't had a patient admitted to the ICU or having any complications once they receive the epinephrine. We've had nosebleeds in 3 cases. We've had allergies to iodine contrast and 1 carboplatinum allergy. We had about 30% of patients would have some neutropenia with an ANC less than 1,000, and about 9% required actual treatment or were symptomatic. The femoral artery, like I said, the reason why we started putting an age limit on there, because you can't have complications from the port that you put in, and for other reasons that we've modified, you have to have a big femoral artery not to have complications. We did have 1 thrombosis of a femoral artery, and then we had some transient ones. We had 3 occlusions of the middle meningeal artery when trying to backflow into it. We had 2 ophthalmic artery occlusions. One of these was, both were in the same patient, and they had a coagulopathy that was unknown. We had an internal carotid dissection, which the procedure was aborted and was an unsuccessful catheterization. And as I'll describe earlier, that was when we were first starting to. So this is inclusive of our entire experience. Now, if we segregated our results to later on, I think it would be much less. But this was kind of pioneering this kind of technique. So ocular toxicity, you can get rashes around the eyes. I'm going over time just a second, but we can get inflammatory reactions, lash loss. And here's an example of the case that we had, the central retinal artery occlusion, and you can get transient optic nerve swelling. So what have we done, and what have we learned, and how do we prevent that? Well, we've modified the way that we go into the femoral artery. We use a 3 French femoral sheath, which is smaller than most of the ones that are used. We don't use a guide catheter. We anticoagulate everyone. We have the epinephrine ready for people that have that response. We use steroids intraoperatively and then afterwards for about 3 days to decrease the inflammatory response. And we use vasoconstrictors in the nose to prevent epistaxis and to the brow to prevent the rash and lash loss. And so inclusion, we had about almost 400 patients, about 1,200 infusions, and there was a fairly, most of our complications were transient. We've learned and made them preventable, and there's a fairly acceptable rate of complications if you compare this to any other interventional procedure. I don't want to waste any more time, but if you have any questions, please let me know.